Hey, good morning, everybody. Welcome to our last spring installment of continuing education. I did want to let you know that the approval code for this presentation is 139822, and it covers all categories, so administrative, clinical, and general. So all categories are included. Catherine, are you starting today?
Yes.
Okay, wonderful. Catherine is going to start with her portion of the presentation, and then we'll take a little break, and then we'll switch over to Carol. So we both have been instructors at Front Range for, gosh, Carol, how long have you been there? How long were you there? She just retired.
1998.
Wow. I started in 2002, so Carol's there. 25 years? Was that 25?
Don't ask me to do the math this early, but
24.
something
24.
like that. Yeah. It's been an absolute privilege, and I've enjoyed it all. And I'm really glad to be able to, do this and keep my skills up a little bit and make me learn something.
Exactly. And Catherine's been there for.
You just asked me all this the other day.
I did. See, it's gone already.
Oh, 2007,
Perfect.
graduated. 2011, full time.
And never to retire. Not before me.
We'll see. You said that the other day too.
All right, so I'm going to go ahead and let you both get started. Catherine, if you want to pop up your, okay, I released the screen for you to share.
Okay. Yeah, I see the share button.
Great.
All right. Yay. Okay. So hopefully y'all can see this. Can I get a thumbs up? Okay. All right, so today we're talking about medical law and ethics. We're calling this the 2022 review. And there's my name in case you've forgotten, haha. The objectives today of the review, we're discussing current medical laws and ethical standards. We're applying ethical principles with a case study. The doctor in question that we are looking at is Dr. Kermit Gosnell, MD. We are then discussing strategies to establish and maintain appropriate professional boundaries, and then ethical challenges as related to COVID-19. So that's kind of our focus here today. Current medical laws and ethical standards. In order to review this, we're just going to go over a couple of the principles of healthcare law and ethics. The top of the list for consideration are criminal and civil acts, contracts, negligence, and ethical concepts as related to the medical professional. Ethical issues are sometimes really hard to resolve. These issues might take place in a hospital or more of a medical center setting, not necessarily a doctor's office. Of course, with COVID, we've had COVID patients that have challenged medical professionals because of the ethical situations that occurred earlier in the pandemic. So why is this important to us? Why are these laws and standards, were they created even? So the common goal, of course, is to always protect and defend human dignity and patient rights. So if we keep that thought in mind, that will help us move forward. Patients' rights include the principle of respect for autonomy. This is the right to make their own decisions, change their decision, which of course may affect the outcome of their health in either a positive or a negative way. And that is sometimes very difficult to understand why people might change their mind. Our goal, though, is to make sure the patient has all the information they need to make an informed decision on this. So This is where we might be explaining a procedure. We might be answering questions to clarify things that they may not understand. And then we might be witnessing their signature on an informed consent form, like for before a procedure. The principle of non-malfeasance, this is the do no harm. Okay, so many healthcare professionals will have this statement in their oath of the profession that they attest to. We see this a lot with physicians and higher level practitioners. The principle of beneficence, which is always hard for me to say, that is what we do helps the patient. The treatment that we offer will benefit them in an expected way. We would want to remove or avoid treatment that might potentially harm them. So again, a patient may have some interesting idea of a treatment that they have read about or Googled. And in that respect, we may have to, kind of talk them out of it, or the provider may talk them out of it because it could potentially harm them without them realizing that. The principle of justice, this is treating patients with equal respect, balancing the patient's needs and societal resources available. And of course, we saw this come into play when COVID started. We had testing unavailable at all, or supplies that were necessary to care for these patients in short supply or totally unavailable. So this is where providers had to figure out, well, who would benefit the most from using this particular supply that we would then be out of. Ethical principles to review. Ethics is the practice of philosophy that deals with right and wrong. So the system of principles and the rules of conduct that is accepted by a group or a culture. So when you think of the medical world as a culture, or physicians, nurses, and medical assistants as groups within that culture, this is where the right and wrong comes into play based on our scope of practice and the standard of care in which we give. So what are some groups that follow a specific set of principles or rules of conduct? This is where you get to go to the chat and type in your answer to this question. Any ideas about this? I kind of gave you a few clues already. Okay, looks like we've got a couple of answers. I wanted to mention as well, we can't, if you don't want your answer to go out to everyone, you can direct your answer in the chat just to myself. So I wanted to have a little discussion about this based on people's answers. We've got some doctors and nurses, lawyers, of course. Yes, very much so. Anybody else? Somebody said churches as a group. Government officials, absolutely. Absolutely. Of course, we see lots of problems with that particular group, unfortunately. Hopefully I'm not slanting this too much for everybody today. All right. Shelters, like shelters for homeless people, domestic violence people, is that what you mean, Rebecca? Okay, I'm guessing maybe that's what you mean. All right, yeah, shelters to help those that are in an unfortunate situation. Yes, I definitely agree. All right. I'm going to close that for now. Mixed in with these principles are the laws that the state and federal governments have that we must follow. Okay, so every profession, every person within the profession at their level has to follow the laws that govern that profession. Okay, so that's the state medical society for physicians and the state nursing board for nursing and so on. Laws are rules that define a person's rights and obligations. So think about the things that we as medical assistants can or can't do. Even though we don't have a state licensure to guide us, we have that national registration or certification that guides our actions on the job. What are some of the laws that a medical professional in the state of Colorado must follow in order to practice here? This is another chat question, if you would be so kind as to answer that. All right. So what laws are we talking about here? Okay. Ooh, yes. Yes. Yes, absolutely. Okay, so good. We've got some good responses here. So HIPAA is something everybody needs to abide by, again, because we're talking about patients' rights to privacy and their protected health information, how that information gets used, to whom it can be released. Yes, absolutely. Child Protective Services, somebody says, suspected abuse. Again, as medical assistants, we may see these signs on a patient in the course of, say, doing vital signs, see bruises present or something on a patient. And of course, that would be something we would bring to the provider's attention so that they could ask the patient about it. It might come off to the patient better that way. Behavioral health is another subject that somebody presented here or popped up here. So yes, definitely. Okay, let me close that. All right. Whoops, how come my slide didn't go on? There we go. All right, so the ethical principles case study is, we're going to talk today about Dr. Kermit Gosnell from Philadelphia, Pennsylvania. Some of you may recall learning of him in your law and ethics class at Front Range if you are one of our students, graduates. This actually came, the subject of Dr. Gosnell came to me from a student. Thank you, Amber, because I've used it for years on end, because I think this story exemplifies the most extreme case of medical and ethical violations that I personally have ever seen. In our country, I don't think anything comes close to it, at least in the last 50 years, as far as in my lifetime, definitely is the worst that I've seen. So we will see many ethical and legal issues with this case study. You might want to make notes as we review this slideshow. Okay. So that's your hint, write it down. So the history of Dr. Gosnell, he was a practicing physician in Philadelphia, Pennsylvania. He ran the Women's Medical Society. He'd been with them since 1979. He was not the he was not the founding doctor, but he did join the practice in 1979. This office provided abortions in the West Philadelphia area. He was not an OB or a GYN provider. He did start, but did not complete a residency in OBGYN as part of his medical training. So that's your first hint there. Dr. Gosnell grew up in the Philadelphia area and came back to practice after medical school. He was highly regarded in the community as the hometown boy. The office provided abortions to the underserved women of the area, where Pennsylvania law stated that procedures could take place up until the 24th week of pregnancy. Pennsylvania law stated that patients wanting to have an abortion had to receive counseling about the process 24 hours in advance of the procedure. This was to allow a patient to change her mind about proceeding to that final step. Excuse me. When the Women's Medical Society opened in 1979, Pennsylvania law stated there had to be an OBGYN provider on staff. And again, I mentioned the founding medical director was a qualified OBGYN physician. But when Dr. Gosnell joined the practice, he was listed as a staff physician. There was also an RN employed as required by the state statutes at this time. The original license to operate the Women's Medical Society as an abortion provider was granted for 1 year, so it expired in December 1980. The expired license of the facility triggered no inspections or reports by the Pennsylvania Department of Health. The Department of Health was supposedly inspected the facility again in 1986. So this was 7 years after opening, although no documentation was found for this inspection. In August of 1989, 2 inspectors did come for a site review. Gosnell was found to be working as the only licensed medical professional. Other serious violations were found, including no RN on staff as required. In March of 1992, inspectors came once again to find Gosnell the only provider on site, but a consulting physician was listed as being on the board, and no RNs were present as required still. Hold on just a moment, please. Carrie, do you know how to mute me so I can blow my nose?
Where's mute? Here it is.
No.
I got you muted. This discussion is kind of timely, Catherine, with Roe v. Wade.
Thank you. All right. The 1992 inspection report did skip some important questions that were left unanswered by the inspectors on the evaluation form, namely about anesthesia and post-operative care. This report also stated that there were no access issues to the building, which was clearly untrue. The building was 3 stories tall, and an elevator was required for that size of a building, but was not present. Despite these unanswered questions and obvious fallacies, these 2 inspectors approved the facility to continue operations, citing no deficiencies. The final inspection on record was April 8th, 1993. This team of inspectors found that nothing had changed. Hallways were more crowded, no nurses were on staff, and Dr. Gosnell was the only provider. Once again, the inspectors didn't note any cleanliness issues, broken equipment, or staff qualifications. They did note expired drugs were found on the premises. Despite these things, the license was renewed through March of 1994. So after the new governor of Pennsylvania took office, or was elected and then took office, elected in 94 November, the Department of Health stopped all routine inspections of abortion clinics. This was just like statewide. Nothing got inspected. Stopping inspections, though, did not stop the reports of injuries to patients of the Women's Medical Society. Back in '96, the health department received a report of a patient suffering from a perforation of her uterus following an abortion at the facility. This injury later required a radical hysterectomy. In 1997, the Department of Health received reports from a pediatrician that had referred patients to the Women's Medical Society, coming back to him with trichomonas, an STD from unsterile instruments that were used during their procedures. In 1999, a patient had complications from an abortion procedure. She was told by Dr. Gosnell that her symptoms were normal. When treated at a local hospital, she was found to be septic from retained fetal parts. She did manage to survive. In 2006, a patient who suffered complications at Gosnell's hands was basically rescued by family members who came to pick her up. They called for EMS transfer to a hospital after being told she was fine. At the hospital, she was also found to have retained fetal parts. In addition to tears to her uterus, cervix, and bowel, she lost 5 inches of colon and required a blood transfusion in order to survive a major emergency surgery. Excuse me. In 2009, a patient suffered cardiac arrest due to oversedation by the untrained staff member. The crash cart needed to revive her was found to be not working. Staff members didn't call for EMS transfer to the hospital until the patient's family member questioned what was happening. This patient died the next day. The report of her death to the health department resulted in no investigation at all. A former employee of the Women's Medical Society filed a report to the Department of Health in December 2001, detailing the horrific conditions that she worked in while she was at the facility. Her list of conditions were later found to be true. Underage patients were being brought in by their parents. Unclean conditions were present. Furniture, blankets stained with blood. Disposable instruments were being reused without proper cleaning and sterilization. Uneducated, excuse me. Uneducated personnel, including herself, were administering anesthesia, performing ultrasounds, and the facility had roaming, flea-infested cats living there. The physician himself would eat during procedures in the rooms. Dr. Gosnell was also participating in insurance fraud, helped by staff members who changed the names on charts so insurance could be billed and paid on behalf of the patients. This employee also disclosed that Dr. Gosnell was writing prescriptions for Percocet for the same people every week. And this is actually what triggered the DEA FBI raid on the facility. She stated that late-term abortion procedures are done on certain days, and fees for such were not being reported to the IRS. The straw that broke this employee's back was being told she would be giving anesthesia to patients that she knew she was not qualified to do. She made an excuse to leave the facility that day and never returned. She filed her complaint to the health department the very next day. In April 2004, the State Board of Medicine, the agency responsible for licensing doctors, recommended no further action be taken on this complaint. They stamped the file prosecution not warranted. Dr. Gosnell's mode of operation continued then with this denial of investigation. As previously stated, as early as 1999, patients were being seen for abortions as late as 8 months gestation. This is considered a late-term procedure, clearly illegal in Pennsylvania. Patients having abortions this late would deliver a moving, sometimes breathing baby. Dr. Gosnell's solution to this was to snip the baby's neck with scissors, basically severing the spinal cord and causing death. Dr. Gosnell also taught some of the unlicensed personnel to do this snipping procedure. Women who came to the Women's Medical Society were often immigrants or women of color who needed abortions. Dr. Gosnell fabricated the ultrasound images of the fetus to make them look under the 24-week requirement for the state statutes. Patients had to pay in cash for services. Patients seeking narcotics also paid in cash to receive prescriptions after their examinations. Dr. Gosnell has been dubbed America's biggest serial killer because of the large number of abortions he has performed. Knowing his method of disposing of fetuses that were born alive, the other trait of a serial killer, excuse me, was his habit of keeping severed feet from the fetuses in specimen cups. Over 30 of these specimen cups were found at the facility during the raid. The lack of investigation into complaints and the general lack of oversight allowed Dr. Gosnell to operate for 30 years in this manner. It was only when narcotics detectives were tipped off by a confidential informant that a joint task force of FBI, DEA, and Philadelphia Police Department, that the investigation was started into the facility. While the DEA and FBI found evidence of drug trafficking, the police detectives were the ones who found the remains of many aborted fetuses in various stages of gestation. Dr. Gosnell had further neglected to have the remains disposed of in the usual manner of cremation or burial. The remains were all over the facility, stored in cabinets and even in the refrigerator that the staff used for their lunches. Here is the trailer for the movie about him. So this worked yesterday.
Is it a documentary, Catherine, or is it like a movie with?
It's only an hour and a half, but it's not really a documentary. It's more of a movie.
Yeah, this is disturbing.
It's really bad.
Ugh.
Hold on. Oh, come on. There we go. Yay!
All right, listen up. We're looking for anything that looks like drugs or paraphernalia. Philadelphia Police Department, we have a search warrant. What is that smell? I mean, you gotta see this.
We don't see any movie.
Oh yeah, Catherine, you have to unshare, then reshare.
Oh, I'm sorry. Hold on, guys. Okay, unshare.
Yep, and then reshare a different screen
Oh,
with the
got it.
trailer on it. Yep.
Got it. Thank you. I'm so glad you're here. Okay, can you see it now? It's not started, but can you see the other screen?
Yep. Good.
Okay.
All right, listen up. We're looking for anything that looks like drugs or paraphernalia. Philadelphia Police Department, we have a search warrant. What is that smell? I mean, you gotta see this. It's normal. I've never been to an abortion clinic before. You would not believe what I saw last night.
How many?
So far, we found over 30. Healthy woman goes into a clinic, comes out dead, and there's no police report. Files been moved recently. Look at this. You'll be the prosecutor who went after reproductive rights, and you'll be a racist to boot.
You've got a lot of folk who'd like to see abortion outlawed. And this is not going to be the case that gives them an excuse.
The prosecution has offered you a plea bargain, Dr. Gosnell. And I would have to admit I was guilty. I'm not guilty. When we get to the courthouse, we're going to be swarmed by reporters. You ready for this, Spencer? Where's everybody?
When was the last time your division inspected Dr. Gosnell's clinic? We had instructions directly from Governor Ridge's office not to inspect.
Couldn't testify in that case about anything. Not to find a doctor who will. Look at the facts. You will see what I see. An overly zealous Catholic investigator. Is that what you want to make this about?
There's nothing that man did that protects women or children, and you don't have to be a pro-life activist to see that.
Kermit Gosnell is perhaps the most prolific serial killer in American history. Better win.
I thought that was Dean Cain, right?
Yes, yeah,
Okay.
it is Dean Cain. So he and Michael Beach and the prosecutor, the actress's name is Sarah Jane Morris. I have seen her in things, but other people were not anybody I'd seen
Oh.
before. So again, the movie shows.
Philadelphia abortionist Kermit Gosnell is serving life in prison for first-degree
hang on.
murder and involuntary manslaughter. It was a heinous case that barely saw national media attention. But for one journalist, covering the case was the unexpected start of a
Sorry. We kept YouTubing. Sorry. Okay. Okay. Haha. So the movie shows that because it had avoided inspections for so long, it never came on anybody's radar until it was suspected of the drug trafficking. And so that's why the Philadelphia Police Department was in on it as well. With drug trafficking being a federal crime, the other two agencies were involved, but the local police department were the ones that, that was Dean Cain. He was the lead detective, guy by the name of Jim Wood. So there were many employees at the office, including his wife, Pearl Gosnell, and she was actually trained as a cosmetologist. That was her background. So nobody else there had any medical training whatsoever. The real shockers of the employees were the teenaged ones. They were very young. He called them medical assistants, which is a total slap in the face to anybody who's really had any medical training. And some of the other women that were there were people who used drugs, might have been Dr. Gosnell's previous patients even. And so they also had no medical training other than being his patient. And they were doing really dangerous things like mixing the drugs that sedated the actual patients. So one such patient had an 8th grade education and a phlebotomy certificate. I mean, wow, that really qualified her for not doing what she was doing. So he had her mixing drugs that sedated. He had a color-coded chart on the wall to show which drugs to give patients based on what he told them, because they didn't know the names. They didn't know the quantities to give. They weren't qualified to be giving those medications whatsoever. Another employee was also unqualified. She had personal medical issues, like she had hepatitis C herself, and she refused to wear gloves. And he didn't seem to care if she did or not. And so that's disturbing as well. Other employees were active drug users who got their supply right from him. So it was very convenient in that respect. Dr. Gosnell paid the employees in cash with bonuses for helping with abortions, or bonuses if they were working the front desk when people came in for their prescription for Percocet, because he was writing those. He kept very odd hours. The clinic was open in the evening. They did some of the late term abortions in the evening, sometimes even on Sundays. So it was very shady. After the raid, his license was suspended and the facility was closed. It took local, state, and federal officials many months to compile the evidence together for a grand jury to review. So if you're not real familiar with the legal process, when a person is suspected of crimes, then they will have a grand jury review all the evidence to see if there's enough evidence to bring forth charges, especially on a state or federal level. Okay, so a lot of the movies showed the grand jury reviewing all of this evidence and bringing forth the charges or recommending what charges to bring forth. It took them over a year to do this process. So it was a huge investigation. The part in the trailer that we just saw, when they walked into the courtroom, were ready for the trial to start, and there was no press. There was no press there. So the mainstream media, or what we would call regular news, this took place in 2013 is when the trial came about. So this was still during President Obama's administration. And the mainstream news was kind of not covering this the way you would maybe expect, because the fear was that it would become more of an abortion case, and it would turn it so that abortion would be outlawed in this country, which, like Carrie said, is now under review. And so the right-wing press had this all over the place. Okay, unfortunately, most of the sources or some of the stuff I reviewed was on Fox News, right? So they were having a field day with this case, because they, of course, would like to have seen abortion overturned that many years back versus now, like it is. So it actually got leaked. The case got leaked. The trial got leaked to a blogger or by a blogger, and that's what actually got the mainstream press into the courtroom. So that was very interesting, because literally when they walked in initially, there was nobody there. Nobody was covering the case. And then it became known what was going on in Philadelphia, and the courtroom filled up after that point. Okay. So Dr. Gosnell was arrested. His wife was arrested. They had a teenage daughter at home. She was shown in the movie at the raid of his house. She was a teenager at that point. That was the youngest of his 5 or 6 children that he has. 9 employees also arrested. On March 18th, 2013, that's when the trial started. He was convicted May 13th, so 9 years ago yesterday, for the involuntary manslaughter of the patient who died in 2009, as well as 3 out of 4 charges of murder of babies born at the clinic. So these were the ones that they found remains of, and they had been there so long that they had actually dehydrated. The remains had dehydrated. In the movie, the medical examiner is shown rehydrating them so that they can determine the cause of death. They were able to determine that the babies were born alive, and that because of the marks on their neck, that they were killed after birth. And so that's where the murder charges of the babies came from. The movie does go into a lot of detail about the different fetuses, the different babies that they were talking about. So they were labeled baby A, baby B, baby C, baby D, and so on, because of course they were unknown. There was no tag as far as who they were from, as far as patient goes. But it was very interesting. The movie was very interesting. It went into a lot of detail, although they didn't show anything really graphic. I was kind of prepared for that. The book had lots of detail. It was a lot harder to read as far as how they found things. Dr. Gosnell was also convicted of numerous drug trafficking charges, was sentenced to 30 years just on the drug trafficking alone. 9 employees, including his wife, were charged with crimes ranging from perjury to murder. 8 employees pled guilty, several went to prison, and several testified against him for lesser sentences. So again, the one who really started it all was a former employee. He is now serving life in prison with no chance of parole. He avoided the death penalty by agreeing not to appeal his conviction. So in the movie, it shows him, not wanting to accept a plea because that would mean he'd have to say he was guilty, and he is a very interesting person. In my opinion, he had what I would call a savior complex. He really thought he was the only one that could help these particular people.
Here you go, that's the rest of it, and then they just have to stay in the packet until you use it because they're light sensitive.
Okay, thank you. You guys have a great day.
Hello. And again, so he avoided the death penalty by agreeing not to appeal his conviction. I think it probably became overwhelming for him to see everything that took place in court. And he is currently 81 years of age. So let's see there's some marks in the chat. Oh, of course. Oh, okay, so Casey, the title of the movie, here's the book. Gosnell with the scissors on the cover. The book was published in 2017, and the movie is the same title. Gosnell. I got them both at the Longmont Library. So as soon as I take them back, you can have them if you so desire. Let's see what else was asked. There's some other question I didn't get to. Yeah. You don't want to binge watch this one? The movie itself wasn't too long. It took me a lot longer, of course, to read the book, but it's very interesting. And like I said, I think it's just such a perfect example of every possible problem that you could foresee happening. So that's kind of my next question. Y'all get to answer some questions now. So, how many legal issues can you list from this case? You can answer in the chat. So you might jot things down. Hopefully you made some notes while we were going through this. So what kind of legal issues could you see happening in this case study? Yes. You saw the stairway, right, when they were raiding the place. So all of those red bag trash bags were fetal remains. So yes, it was everywhere. Staff unqualified, absolutely. Anything else? The fridge, yeah, I know, too many to count, yeah. Yeah, can you imagine working there? Hello? Yeah, even the doctor not really qualified, absolutely. Anybody want to expand on what they thought was the biggest issue and speak to the group?
I have a question, Catherine. It's Vita. So why they didn't prosecute when they found those violations, at the beginning in 90s? So why nobody would go after that right away? So it wouldn't, go on
Basically,
for years.
yep, the book went, worked on that a lot. Basically, the people who did those inspections didn't really care enough about what they found to kick it up to the next level. Or if they did report it to their superiors did not act on it. There was just a horrible breakdown in the chain of command in the health department that that kept it from being, he could have been stopped at so many points because he was already in trouble so early on. And he just did not, they didn't care enough to do their jobs. And even if the ones that were there did, the ones above them did not. So yeah, that's how it went on for that long of a time. With, like I said, no oversight. Everybody kept giving him a free pass. And that's sad. To me, that's just crazy because these people were responsible for the health and safety of patients that came to facilities. And he wasn't the only facility that wasn't getting inspected, especially after Tom Ridge was elected the governor, which was 94. He was the November 94 election. So from 94 until whenever he was out of office, no inspections were done at any facilities in the state of Pennsylvania. Yeah, so yes, y'all got some things here. Yeah, and it just snowballs. I mean, once he figures out that, hey, I can do exams on people and prescribe them drugs and make a lot of money that way. I mean, they were paying $150 a patient for their exams that were basically nothing more than him looking at them and writing a prescription. And then they were coming back with, they were coming back every week and getting a new prescription. Now, who is QMKMPIER? I don't know who that is. Karen. Okay. Karen. Which Karen? I know a lot of Karens. Which one?
Pierdzioch. It's Pierdzioch.
Oh, okay. Okay, good. Okay, thank you. Yeah, he was an interesting, like I said, very interesting character. And I think, the longer he went without oversight, and the more he just didn't even have a threat of being caught, then he just kept it up. Yeah, reminds me of a back alley transaction that nobody knew about. Yeah, absolutely. Yeah, I mean, people in the neighborhood knew him and what he was up to, but nobody dropped a dime on him. They wouldn't come near the place because they knew it was evil, basically, is what the detectives heard about it. So how many ethical issues can you see, or what's the difference here? Kind of all is hard to distinguish, huh? You got the legal side because he was going too late in weeks of gestation. And then ethically, the conditions, I think, fall under more of an ethical thing because, you're supposed to keep things clean and safe for your patients. So if you try to define it a little bit. Any ideas there or anything different there that anybody can think of? What do you see as the likely moral issue in this case? there's one thing that stands out to me as being a moral issue.
Killing babies, they're already, formed and alive.
Yep. Yep. What else? Anybody else think of anything that's kind of well known for being
They didn't sterilize the equipment properly as well, giving patients infections and also the drug use, giving them all those drugs.
Yep. Yeah. The female the patient who died, the adult who died after the abortion in 2009 was an immigrant from Nepal. And she was an older lady. She was actually 41 or 42, got pregnant, had not been in the United States very long, had a grown daughter who took her to this appointment at the clinic. And she was the one that called for the ambulance after after they told her, that there was some problems. She was also the one that went into cardiac arrest, and then that's when they found the crash cart not working. This woman, when EMS responded, it took them 45 minutes to get in the building and to her and to get her out of the building, because it was such a maze of corridors and hallways. The building itself was very old, and he had bought the one on each side and connected them interiorly. And so there was no elevator. Yes, Amber, there was no elevator. And so they had to get in through all of these narrow corridors, narrow hallways to where this patient was and get her back out. And it wasted 45 minutes of getting her to the hospital, where she could have been seen much sooner. And who knows if that would have made the difference with whether or not she would have survived. But it was just, again, super, super scary, super unnecessary, that kind of thing. I think another problem I see with providing this service, again, regardless of whether or not you think abortion is right, if it's going to take place, then do it legally, do it in a fashion that's not going to harm patients. The way he did things and the people he had working for him just made it a nightmare for basically, everybody that came into the place. Granted, some people did fine or whatever, but yeah, otherwise it was not a good thing. I think the big moral issue that I see with him, at least, is I think he caught what I would call the greed bug. Right? He found out he could make a lot of money, think of himself as still providing a good service, but I think he got greedy, and I think he found it was an easy way to make himself rich. That plastic tote of money that they dumped out that you saw in the raid trailer was one of many stashes of cash that they found. That particular picture was at his house, but they found money stashed like that in the office as well. Yeah, hopefully there were some people that did turn away and didn't go there. But again, now we see this being challenged, with the Supreme Court, and people are all abuzz about what's going to happen to women who can't travel anywhere to get an abortion, and who have limited resources. So, I mean, he was charging $2,500 for late-term abortions. So it was not It was not cheap. That's for sure. Oh, absolutely. Yes, the woman, barrier for communication is what somebody just said. The woman from Nepal knew very little English. She didn't speak much English at all. So definitely a barrier in the communication with her. All right, so let's move on. There's other things to talk about. Okay, so we're talking about professional boundaries today too. So establishing and maintaining appropriate professional boundaries. So first off, why is it important? Is it a big deal for us to be friends with our colleagues or patients on social media, perhaps? So the big deal, of course, is that we want to maintain our patients' trust in our practice. So this is why we have to have that invisible boundary, and keep that, not necessarily so that we don't know our patients, but just so that there is just some edge to the way in which we know them. Because of the patient's trust, we don't want to make them question our professionalism or the way we run the practice, because then they may not be comfortable coming to our office. The not maintaining professional boundaries could potentially cost the office their reputation in the community. That's why we always talk about.
I'm still doing my meeting. I just have to use the restroom.
Somebody's not muted. So if a patient is uncomfortable in our office, they're likely to tell their neighbors or their friends about the experience that they had at our office, and that could cost us our reputation or some patients and that kind of thing if the word spread, of course, depending on the type of community in which you live in. Becoming friends with patients through social media can be damaging to the practice, again, through word of mouth. You don't need your personal social, political, or religious views spread by patients, which potentially, in my opinion, could damage your reputation. If you had some really unusual political views or religious views, and your patients found out about it, they might question your employer. How could you have this person working for you, with how she writes, about on social media, that kind of thing. Most professional boundary issues are related to allegations of sexual misconduct. So again, this is something that providers and higher level practitioners, doctors and so on, might have to worry about more so than us as a medical assistant. So male providers would always want to avoid these issues of sexual misconduct. And again, the AMA has some very good information about how to do this, and that's what we'll talk about next.
Catherine, I actually had to change my intake form, and on the back, there's several things that they have to initial because my procedure is a little bit different, and there's a lot of touch, and there's definitely a couple of things that are explaining that I'm not touching in a sexual way, and that there can be no relationship between me and a patient, because I've had this problem actually quite frequently. It's stressful.
Yeah, well, and I was going to mention, the only thing I can relate to in that fashion is when I've been to Pilates class and the instructors want to help you make sure you're in the correct form and you have your feet right and whatever, and they always ask permission, and sometimes they just do it as a blanket kind of thing at the beginning of class. Does anybody have an issue with being touched today? Because if I see something, I want to correct you, because you could potentially hurt yourself if you didn't have your feet in the right form or whatever in the right place. And that's what they don't want you to get getting hurt. So, but yeah, I mean, I can't even imagine being in more, being in a situation of actually needing therapeutic touch in order to do your business. So patients should always be allowed to undress and dress in private, and always offered gowns and drapes to cover with. Questions asked about sexual issues and histories should always be done when you're fully dressed, or when the patient's fully dressed. Only ask questions about during an exam of breasts or genitalia if it's related to something that they find while they're actually doing that exam. Communicate clearly with patients about reasons for and the ways of examining them. Obtain verbal consent prior to any exam, because again, it's CYA basically, right? We're trying to cover our assets, is what I call it. So have a chaperone in the room whenever possible. Document who the chaperone was by name and title. Offer the patient the opportunity to speak before or after the exam when the chaperone isn't present, because a lot of people would be hesitant to speak up maybe when the chaperone is there, or ask about it again once they're dressed and that kind of thing if they have any other questions. For anybody employed in the office, of course, this is very general for everyone. Do not accept or give gifts. Avoid contact outside of the office with patients. Keep your private life separate from your personal work. Be a good role model for professional behavior for others. Avoid excessive self-disclosure to patients. Okay, they don't need to know about your whatever, your hot date on the weekend. That's one of my pet peeves, is listening to people who are supposed to be helping me talk to others about their wonderful weekend in Paris kind of thing. So yeah, that's a no-go for me. Any other ideas about professional boundaries that people can think of? There's a comment in the chat. Let me see what that is. Somebody needs more coffee. Do not have favorite patients. Absolutely. Yes. Because what does that go against? If you're holding somebody, close to your heart, what happens to everybody else? Right. So yeah, it's really not, it's not showing, yeah, you're showing favoritism to somebody else.
Exactly. It's like having favorite students.
Absolutely.
We have them. We just don't let anybody know we have them.
You just don't talk about it.
That's right. I mean, most of them are here, actually.
I was just going to say, they're the ones that come and see us forever. Unfortunately, you see it all the time at work, huh, Karen? It's not good. Oh, yeah. Again, it can be difficult. Just because patients can be difficult at times, it can be difficult to treat them justly, maybe, because they're being a little more needy, or asking a lot of questions and needing a lot of help or whatever. But sometimes you have to do that because they're in that spot of life where they need that assistance. All right, let's keep this. Since, okay, so we're moving kind of into the COVID stuff, okay? So ethical challenges related to COVID-19. So since January 2020, the world has seen what we call unprecedented challenges to the health and safety of our population. When COVID-19 first appeared, the swift spread and many unknown factors led to much mistrust or distrust and disbelief that it was very serious, okay? Public health officials were ridiculed for the lack of knowledge about the virus, and this led millions of people to take no action or to believe in untested cures. Dr. Google, like most healthcare professionals, these officials were trying to do their jobs with the information that was available at the time. When more facts came to light, then the recommendations also changed. And we've seen this evolve in the last year, 2.5 years, basically almost. When public health advisories first came out, some people were reluctantly or stubbornly refusing to do the simplest steps. Washing hands often throughout the day, keeping hands away from your nose and mouth and eyes. Large gatherings being limited or curtailed altogether, restaurants and other venues closing, keeping 6 feet away from others while waiting in lines for, everything that we waited in lines for. Masks should be worn when you're out in public around people you didn't know. And of course, we saw this everywhere. We saw the problems it created everywhere. And to me, it was kind of mind-boggling, actually, to have had such civil unrest. Since then, I've read another book. If you want another book to read, I'll tell you about this other book that really shows some horrible societal breakdown. We'll talk about that in a minute. With the severity of the pandemic, we saw the shortage of medical supplies, which hit healthcare workers the hardest. Without adequate PPE, healthcare workers joined the ranks of the sick and dying. The shortage of medical equipment such as ventilators and other supportive supplies left healthcare workers in a position of deciding who gets the valuable items when there was obviously not enough to go around. The pandemic served up new questions of medical right and wrong. Managing risk responsibly is always going to be first and foremost. Right? So the sick and dying were separated from their loved ones once they entered the hospital. This separation left patients dying with only medical staff to comfort them or for the family to view them on video. The trauma to survivors and hospital personnel of this time will likely haunt them for the rest of their lives. I don't see any way that you would be able to recover from things I've read and heard. As the pandemic has run its course, we have learned many lessons from both behaviors of people and of the virus. The behavior of people has been shocking, to say the least. Surprising revelations that have sometimes led to a person's demise. I mean, people who defied the health department's no gathering, suggestions. Sometimes, did not survive. They passed the virus and got sick enough to kill them. The virus then, of course, has mutated several times, and the strains now are posing new challenges to the vaccines that were originally developed. So only time will tell who the winner is going to be, right? Are we going to be able to conquer this sufficiently enough that it becomes, more in the background and not have widespread issues with it? The biggest ethical challenge, I think, in my opinion at least, is to educate the population in basic science and to establish trust in the dedicated and educated professionals who've made this field their life's work. That to me is key. We've just got to up the education and not everything is a conspiracy to keep you out of the bar on Saturday night. So how do these challenges or ethical challenges relate to our work as medical assistants? Remembering HIPAA with confidential patient information in medical records and in communication. Encourage patients and family to remember the basics of, again, public health, masking, washing hands, distance, and so on, especially those with underlying conditions. There's still so many people, although they've survived, being around others with COVID, they still have, they're still fighting cancer, or they still have diabetes, or whatever their underlying condition that makes them more susceptible. They're not out of the woods by any means. testing when appropriate, quarantining when awaiting test results or when symptomatic. We ourselves should not give advice to patients unless we've been trusted with that information to pass on by our employers and providers. And of course, not misrepresenting yourself as a higher level medical professional. That to me is key. You don't ever want to be putting yourself in a position to be thought of or misconstrued as a higher level medical professional, because then you could potentially cause yourself legal problems because people think you are the nurse. Okay. And to me, that's really important. If you don't take anything else away out of this horrible thing, please remember that. Any other ideas related to COVID-19 challenges that anybody can think of?
It's Vita. I remember when it started, like very, very early stage, they said like, oh, we don't need masks because we had a shortage of masks, do you remember? Like, oh, nobody wants to wear masks. And then like, oh, no, you need to. So it's like, it's controversial, you know, they say one thing, then they say opposite, and then something else coming on. So it was too many sources with information that personally, I would know like who to trust, what to believe, and what to do.
Yep, exactly. And I agree. Jenna says we shouldn't have to have a pandemic to tell people to wash your hands. Yeah, I mean, it's crazy, and it shouldn't be the least bit political. Somebody else mentioned politicizing things. Again, yeah, they're two separate arenas. And the fact that we had government officials not setting good examples, I think totally made this so much harder. And people need to be on board with anything related to public health because it affects everyone. It's not just, you know, California or, you know, it started in Washington State, and it moves so fast. I mean, who remembers the maps on the news and, you know, all the cases showing up, and it was just going everywhere. And it was like, I was like, this is going to be really, really ugly. This is going to be really ugly. And we've had over 1 million deaths in this country, and that is just shameful. It's totally, I mean, who knows? I mean, who knows how many could have been avoided is what I would like to think, if people just embraced the science and didn't believe it was, like I said, just a conspiratorial plot to keep everybody, you know, to keep everybody home. Yeah. Okay. It's break time. Does anybody have any last minute little? Yes, Amber, I agree with you. It's so hard to think that people still think that way. It's crazy. All right, let's take our little break. How long, Carrie?
We could do, why don't we do 10 minutes? I know Carol has a lot to cover, so let's do 10 minutes.
Okay. Do you stop the recording?
Yeah, I'm going to pause the recording.
Got it. I'm going to stop the share. Okay.
See y'all in a few. I've been listening.
She's been wandering around my house.
All right. Welcome back, everybody. Carol is now going to begin her highly anticipated session.
Good morning, and it's really good to see some of you, even though I don't see your picture right now, but thank you for coming. And so I decided to do a CEU on SARS-CoV-2. Definitely in the news a lot. There's just so many numbers going around, so much information. So it sort of forced me into studying and learning about things and simplifying it, just getting some basic facts. I'm also very interested in infectious disease and read several books prior to this on pandemics. So this is a personal interest of mine. So here we go. So SARS-CoV-2, that stands for a severe acute respiratory syndrome. It's a coronavirus. It's number 2. We'll get into why it's called number 2. It's oily. It's a 100 nanometer wide bubble of genes. Okay, I need to move this, Catherine.
Yep.
So
No, just,
how do I move the pictures? To move.
no. You want them off?
It's covering my writing, like part of my slideshow.
Oh. Oh, oops. Okay.
I think,
Yeah, just move the whole panel, like you can move it over.
can I grab it and move it? There we go. Yeah, I just moved y'all to the other side of the screen. Do you enjoy that ride? So one of the books I read was called Apollo's Arrow by physician Nicholas Christakis, and I'll start with that. So it kind of sounds like the beginning of a horror movie, but in the late fall of 2019, an invisible virus that had been quietly evolving in bats for decades leaped in an instance to a human being in Wuhan, China. It was a chance event whose most subtle details we will probably never know. Neither the person to whom the virus gravitated nor anyone else was fully aware what had transpired. It was a tiny, imperceptible change. This sort of reminds me of the saying about a butterfly that's in, you could say, China, flutters its wings, and it ends up creating, a hurricane in Florida. That that movement of wind just it transfers around the world. And why is that not
Right here.
Oh, just
Move
have
the
to.
wheel. Yep.
Okay. New equipment.
No, go, you need to go the other way, because it's not, there you go. Go.
No, this is it.
Goes there.
Okay.
There you go.
And I'm going to be moving. Can I move this down to the bottom?
Yeah, you don't have to.
All right. I'm going to have to move you all around. Now you're at the bottom of the page. So one of the interesting quotes read in a book about the plague. Everybody knows that pestilences have a way of recurring in the world, yet somehow we find it hard to believe in the ones that crash down on our heads from a blue sky. There have been as many plagues as wars in history, yet the plagues and wars take us equally by surprise. And that's author Albert Camus. He wrote a book about plague in 1947. I'm gonna get it. I think I'm going the right way now. While the coronavirus causing the 2020 pandemic is new, we've lived with coronaviruses for a very long time. In our human species, 4 types are endemic, meaning we have reached a French word, détente, which means a sort of relaxation living with these pathogens. We have become biologically, socially accustomed to them. These 4 types cause nothing more than the common cold, again, the coronaviruses, and they account for 15 to 30% of that nuisance condition of the common cold. Just a little fact here, more than 200 different virus species, including coronaviruses, cause colds. So we're kind of outnumbered there. The word novel pops up a lot, so I wanted to define that first. And it means a new pathogen of a previous known type of virus. So novel coronavirus, they called it NCOV, was a provisional name given to this coronavirus of a medical significance before a permanent name is decided upon. And although coronaviruses are endemic in humans and infections normally mild, such as the cold, the cross-species transmission has proved sometimes unusually virulent, and it causes viral pneumonia, in serious cases of acute respiratory distress syndrome. So people around the world commonly get infected with these. I'm kind of moving the cursor around. They have number names and letter names also. And they infect animals, they evolve, and then they make humans sick and become a new coronavirus. And so the three new recent examples are 2019, the one we're dealing with now, SARS-CoV, we'll call that also 1, and the MERS-CoV, the Middle Eastern. And so humans have had a run-in with serious coronaviruses before our CoV-2. And they cause a lot more than the, wintertime sniffles, even though I find a common cold pretty miserable. I end up having man colds, if anybody knows. So, but this one, and some of you may be too young, but I didn't pay a lot of attention to this, a little bit. But in 2002 and 2004, there was an outbreak of SARS, COVID-1. And it, again, the severe acute respiratory syndrome. And it affected about 8,000 people from about 29 countries and territories and resulted in about 800 deaths. It was, it's also, the source is from a bat, and transmission is airborne. Like I said that. If you look a little bit at the map, this one did start in China. And there were cases that a little bit in Eastern Europe and in the US and in Canada. But let's see where I want to start here. So this form of the virus was responsible basically for the 2002-2004 outbreak. And it's very similar, or the current one we have, it's very similar to this one. And that's one reason that, there was a lot of alarm at the beginning of this pandemic, or before it was a pandemic, because it infects the epithelial cells within the lungs. And it the virus uses the host cell by binding to the ACE2 receptor. This one, the COVID-1, infects humans and bats and palm civets. And I think that's like a civet cat. I mean, it's not an animal I'm familiar with. But the last case of this was reported in 2004, and it resulted from a laboratory-acquired infection. The second deadly coronavirus to rear its face on the world stage was MERS, the Middle East respiratory syndrome. This started in 2012, and it had basically the same symptoms of SARS-1, and we didn't know what the future was with SARS-2, but it's, severe respiratory illness, fever, cough, shortness of breath. It differs from our current SARS-2 because about 3 or 4 people out of every 10 died with MERS, have reported to have died with MERS. It was named kind of from the area of the world that it first presented, and its original host tended to be bats, but over the years, an intermediate host of camels have acquired it, and they believe decades ago that they acquired the camels. And so that's one of the ways it's transmitted, with an infected camel or a camel product. People in that part of the world culture use a lot of camel products, camel milk, camel meat, hides for, carpets, rugs, that type of thing. That can lead to infection, and so can substantial contact with another infected person. It's 3 times deadlier than SARS-1, but the human-to-human transmission is not very easy. In sporadic cases, small clusters, large outbreaks have been reported in 24 countries over with about 9,000 deaths as of 2021. It is still endemic. It is still infecting people in that part of the world. And recent research that I found, her mouse is different than mine. So here I'm going to introduce a couple of new words. So evidence found human transmission of MERS in April of 2022, just last month. And it's a novel, lethal, zoonotic disease of humans endemic to the Middle East. So we'll talk about those words in a few slides following. And it's thought to be acquired through contact with camels and camel products. It carries that 35% mortality rate. And unfortunately, there's no specific treatment for MERS as supportive, and there's not a vaccine for MERS. So this is a place where lots of visitors travel to, the Middle East each year. And there's a lot of high degree of surveillance and clinical awareness, and trying to find early diagnosis with the rapid implementation of infection control measures. What keeps me awake at night is this one that's not that easily transmitted among humans, meets one of our Omicron variants that is easy to transmit, but it hadn't happened yet. And so this is a busy slide, but a little bit just to talk about a zoonotic disease. It's a disease, infectious disease caused by pathogens such as a bacteria, virus, parasites, prions. And they jump from an animal, which is usually a vertebrate animal, to a human. And then the first human infected transmits it to another human, who in turn infects it to another. And, we end up with a pandemic. So the bat, infects, I'm assuming this animal here is the civet cat or palm civet, and these are human beings. It's worth noting that our recent modern plagues have all been zoonotic, coming to us from wild animals. And just a little scary thing that I found was there are about approximately 1.6 million undescribed viruses thought to exist in mammals and birds, and about half of them are estimated to have the potential to spill over into humans. That doesn't mean it will be a fatal, lethal disease. But things that are driving that are like climate change, unsustainable agriculture, exploitation of wildlife, land use changes, deforestation, biodiversity loss. A particular pathogen may affect another insect or another animal, but it's becoming what's the word I'm looking for, extinct. And so it has to find a new host, and often it will be humans. And so we're all in this together. And then I found a slide, the ECDC, and that's the European Center for Disease Prevention and Control. It's an organization, institution, a lot like our CDC. And I pulled off this MERS update from May 6, 2022, just a few days ago. And it was, the bulletin was, since the disease first identified in Saudi Arabia in April of 2012, 2,600 cases in the Middle East have been detected in 27 countries. In Europe, I won't go into that. I'll just skip that about the 2012, but it sort of fizzled out a little bit. But in 2022, and as of May 3rd, there have been 2 cases that have been reported in Qatar. I didn't want to mess up before I've been listening. How do you pronounce that? One of our presidents really butchered that word, and so I wasn't going to do it. And unfortunately, there was one death. And both cases were reported, the people were reported having contact with cows. prior to that, prior to this May 3rd, 2022, the last case of MERS had been in February 2020. I'm gonna keep you up at night. And I just wanted to show a little bit of a map here where it is. Qatar is right around here, okay, the Middle East. And I've included the link on here if you to the ECDC, the European CDC, if you want to, you know, get further information. It's one of the benefits of doing a presentation like this, and just find new resources. And so just talk a little bit about the difference, you know, my vocabulary since COVID has become pandemic in the area. I've learned lots of new words, and you know, I'd learned these for a test, I think once way back in nursing school, but endemic is, I'll just say it's native to or limited to a certain region, such as the MERS COVID virus disease. It's endemic to the Middle East. Malaria is endemic to parts of Africa. Lyme's disease is endemic to New England. Then kind of pushes the boundaries out of that area and becomes an epidemic, infecting a large amount of people within a community, population, or region. And then pandemic, you know, drawing on your medical terminology background, foundation. It's when the epidemic spreads over multiple countries and continents, you know, occurring over a very wide geographic area. You know, in this case, it's global. So here's an artist rendering of the SARS-CoV-2, and as the spike proteins represented in kind of the reddish orange there, and the receptors are on the target cell are represented in blue. These are very important because it's how it binds. It takes the little corona spike protein and it latches and it enters through this receptor, the ACE2 receptor. So what is an ACE2 receptor? I kind of knew about ACE2 receptors with some hypertension drugs. And so this expanded my knowledge a lot about it, but it's a specific protein. It's on a lot of cells, but it allows that COVID-2 to infect human cells. You may remember angiotensin converting enzyme drugs, but that's what the ACE2 receptor is. And the proteins provide that entry point. The coronavirus hooks onto that cell and it enters the cell. And why is that important? I mean, yeah, we know viruses enter cells, but this particular ACE2 sort of enzyme receptor, it has functions in our body. We produce a angiotensin 2 protein, Ang2, and that increases blood pressure, inflammation. It causes damage to blood vessel linings and different types of tissue injury. So the ACE2 sort of modulates that. There's a whole sort of cascade, but with the virus, when it comes up to the ACE2 receptor, it blocks its functions, and then the virus actually gets inside and it replicates. But by blocking the functions of it, it allows the angiotensin to do some harmful effects. That angio2 contributes to lots of organ injury, especially to the lungs and the heart. And so that was one of my other big questions. Why does coronavirus seem to cause so many different symptoms? I mean, this flew through my son's family, and the kids had vomiting and diarrhea. you know, my 13-year-old granddaughter had a headache, and my son had it the worst. He had high fever, cough, you know, a lot of respiratory symptoms with it. And so I just, how does that work? I mean, I think of this as a respiratory type of virus, and it primarily is, but the ACE2 receptors that are present on many cells, all these tissues, lungs, hearts, blood vessels, kidneys, liver, GI tract, reproductive organs, and especially in epithelial cells. Those line a lot of our tissue, especially our respiratory tissue organs, and create protective barriers. And ACE2 is especially present in these epithelium of the nose, the mouth, the lungs. And then particularly in the lungs, it's highly abundant on a cell, you know, pull back on, you know, some of your anatomy back into here. The type 2 pneumocytes are present on the alveoli, which is, you know, the little air sacs where gases are exchanged. Very, very important place. So with COVID virus, you know, covering up, connecting to the ACE2, it prevents the ACE2 from the angiotensin from doing damage to those tissues. And again, kind of repeat here, the angio2 drives lung injury because there's a decrease of the ACE2 activity because the virus is bound to it. And the ACE2 can't break down the Ang2 protein. I know all these ACE and Ang and stuff. I've been practicing this for a while, so it's in my brain a little bit more, but it was a little difficult to understand it, but I'm glad I chose this and went into it a little bit more. And I presented this to my husband and daughter last night, and they understood. I mean, they got it, and were actually, you know, pleased to understand it a little bit better. And so while the virus tends to primarily infect, you know, the respiratory, the lower respiratory system, the kidneys, the liver, blood vessels, all those can be damaged because of the virus sort of hogging onto the ACE2 receptors. So now we're infected with SARS-CoV-2. So the concerning thing at the beginning was it has a lot of similarities to the original SARS, which had a pretty high mortality rate. But it was pretty lethal, but it disappeared pretty quickly. So the viruses latch on the ACE2 receptors on cell membranes at the back of the throat. Perhaps 100, 500 virus particles work in concert and are enough to infect and invade. So they merge into the cellular membranes, your cells, they take over. They take over inside the cell and produce innumerable copies of themselves. And as the cells get more infected, they burst. That new virus, cellular debris, drops down the throat into the lungs, where the tissue is covered with ACE2 receptors. And so it gets down into the lower lungs, and that's where coronavirus does most of its lethal work. So we've seen, we talk about, this was a surprising thing to me, the clinical spectrum of SARS-2. People are asymptomatic. We are blessed. This doesn't really affect many of our pediatric population. So people are asymptomatic, and the only really, wouldn't even call it a symptom, the sign of it is they would have a positive test. Okay. Then we move on to mild illness, and fortunately, this seems to be the dominant way it presents in most of our population. We have signs like with fever, cough, sore throat, malaise, headaches, muscle pain, nausea, vomiting, diarrhea. The unusual ones, the loss of taste and smell. with a mild illness, they do not have shortness of breath, dyspnea, or abnormal chest imaging. There's kind of experts have started separating it. You know, if you get the shortness of breath, difficult breathing, it's moved up a level. So it's a moderate illness at that point. And it's just interesting to me that the pulse ox will be less than 94. I'm reading. I think I put that in. It's greater than. So it would be less at sea level, but we know at our altitude we have to take that in consideration when we look at pulse ox on people's then at different elevations. So SARS-2 and different people my age can progress very quickly to severe illness. They have one of the signs that you might see is a pulse ox of less than 94% at sea level. I won't go into the arterial one. That wouldn't be done in the office. Or you might, a chest film would certainly be ordered, and you might see lung infiltrates. And they're just substances that are denser than air, such as pus, blood, proteins, which sort of start accumulating in the lungs. So they'll see that on the film. You start seeing critical illness. People will start having respiratory failure, septic shock, multiple organ dysfunction. So in this great slide here, how it can affect the many different organs. Again, that's just such a fascinating property of this virus. But it can go, headaches. I had a virus or a cold. I don't think where I didn't have a headache, but encephalopathy, Guillain-Barré. Gasia, I think I pronounced that right. That's the loss of taste, myalgia, anosmia. And I always think of Carrie's slide with the woman with the toilet paper on top of her head. when I think of that, I think that slide was for the rhinorrhea, the runny nose. But anyway, that's the loss of smell, which is unusual. That's really scary to me. Loss of taste and loss of smell, because that's the nervous system that this virus is latching on to. I mean, it's so we don't know a lot about it. Severe renal injuries, proteinuria, hematuria, blood in the urine, elevated liver enzymes, bilirubin, the common GI effects of diarrhea, nausea, vomiting, abdominal pain, anorexia. Gets more serious, especially with some people in my family with the thromboembolism, the deep vein. These people become hypercoagulant. And so they can form clots and throw them to their lungs. A lot of cardiac problems, myocardial ischemia, acute cor pulmonale, endocrine, especially someone with diabetes, hypoglycemic, can shove them into ketoacidosis, and a lot of skin stuff. So petechiae, libido reticularis, red rashes, urticaria, vesicles, hernia-like lesions. So I kept that slide in there. So the funny thing about this pulse ox right here that I pulled out, 86 or 59, but either one of those is measuring. I don't know which one's which, but they're pretty bad if that is the pulse ox.
Yeah.
59, I'm not sure they're going to be still talking to you. But the common symptoms, a cough, this man has a headache. I'm not sure this man can smell, and this person can taste. Sore throat. Here's a slide right here with petechiae, and that's the, we call this chilblains. I'm old. And I think I've seen it referred to as COVID toes, but anyway, and then this here is DVTs. Don't get excited, ladies. This is my husband's legs. He just formed DVTs recently, and and we're lucky he's alive. And it formed in the left leg. We drove across country recently, and the right leg moves a lot when you're driving. You know why? Because you're moving the gas pedal and moving, the brake. The left leg just sits there. That's where it formed. They formed way up right up here, this popliteal. But anyway, it's a very scary thing, and it broke off, and it caused pulmonary emboli, not due to COVID, but just sitting in the car. But you could see the swelling. Anyway, I thought I'd show off his legs. But I want to move forward here about testing. And even with mild symptoms, don't delay tests, because treatments have to be started really early. Not quite as early as some of the flu, like the Tamiflu, within 40 hours, but treatments usually have to be started within 5 days of the first symptom. And you're thinking a scratchy throat, you just don't feel good, maybe you don't even have a fever. But that starts your clock ticking there as far as being able to qualify for medications. So get tested as soon as symptoms start. And we don't see these as much as we used to. Carrie did a lot of testing. What we want to encourage our patients to do if they get confused is to do the test for the viral test. There are tests for antibodies, but that particular test tells us about past infection, not about a current infection. So your patient may call and need clarification on what type of test to do. And that one, there's a blood test, other are nasal tests. And I'll go into these a little bit further in the next slide. With the two types of viral tests are the PCR and the antigen test. And this is a busy slide, but I think, see, I gotta move y'all over here again. Let's see, there we go. So infected, I have the virus in me, doesn't equal that I'm infectious, that I am shedding enough virus to infect another human being. So the PCR, I'll just read it to you because you probably can't see it very well. It's the polymerase chain reaction. It is the gold standard for detecting coronavirus infections. It detects small amounts of genetic material in a specimen. It amplifies it. It makes lots of copies of that genetic material so it can detect it. It's highly sensitive for diagnosing COVID-19. The drawback with it can be positive after you're no longer contagious. They can still pick up particles 3 or 4 weeks after you've had the disease and you're well. And this has been a problem with people like going back to work. I need a negative COVID test. Well, if it's a PCR, sometimes it will still show a positive a month after, and you're no longer, you might have a little bit of the virus still in your nose, but you're not capable of infecting another person. So recent stuff I was reading, looking up, is that, it's small amounts of the virus still being amplified. And this was a reputable source, thought that after 7 to 10 days, that it might not be appropriate, the appropriate test to use if you're trying to get back to work, if you're really, no longer sick. And so these are very useful. The PCR are needed after you know you've been exposed to COVID, or you suspected you've been exposed to COVID. New research is supporting there were most infections. We know we shed it, prior to being symptomatic, but new research is showing that we tend to be most infectious 1 to 2 days after symptoms have begun. And that those are the days we're at the highest risk of infecting others. And I mean, this is all a moving target. I mean, this can change and be very different tomorrow. So, keep up with it. But it's certainly going to detect the COVID early in the course of infection than the less sensitive rapid antigen test. That's the one that's being mailed from the post office. It's available at POC facilities, the home test. And I gotta move y'all again. Up there. It's best used after you've had COVID several days, symptoms several days, and to confirm that you're no longer infectious. And it was recommended that you use it towards the end of the 5-day isolation period. You get symptoms, isolate 5 days. That may have changed. The CDC does change frequently as new information comes out a lot. And it was recommended if that was positive after 5 days, you isolate another 10 days. The rapid test has a lower sensitivity to detecting smaller amounts of virus. So in that way, it's inferior to the PCR test. And it only picks up the virus if there's high levels of present. And we know that current research is supporting that higher levels present tend to make us more infectious. So experts are thinking that the rapid test is better than the PCR at capturing when people are exiting their period of maximum infection. And I mean, this is all on a scale and, almost kind of like a bell curve. And, there are always outliers. There are people that will be infectious 14 days out and people who are not infectious, 2 days into their illness. But we do kind of what's in the middle. It's a learning process for a lot of people. So if you test positive for COVID and you have one or more of these health conditions, if you kind of go across the top of there, it really increases your risk of becoming very sick with COVID. And this is why I'm really, stressing get tested right away and treat so you can get treatment right away. It may be available. Contact your healthcare professional, which is going to be maybe you answer the phone. And so don't delay, treat or test and treat right away. That's a little Right. Thank you. I've always had this little delay of the words back here. It just takes a while to come out. Yeah. And so here I have a link here. So medical conditions that put people at higher risk. I'm not going to switch the slide. I'm going to go online and look at that, but I'll just tell you that in illnesses that increase the risk of serious COVID are certainly cancer, cardiovascular disease, chronic kidney disease, chronic lung diseases, chronic liver diseases, cystic fibrosis, both type 1, type 2 diabetes, disabilities, ADHD, cerebral palsy, birth defects, limitations on activities of daily living, skills, intellectual, developmental disabilities, heart conditions, HIV, mental health disorders, mood disorders, including depression, schizophrenia, neuroconditions, dementia, obesity, people who have immunodeficiencies, pregnancies, recent pregnancy, physical inactivity, smoking, or current or former smokers, organ transplantation, tuberculosis, use of steroids or immunosuppressants. So a lot of people are at at risk of getting serious disease from this. So I am, my husband am. And so let me move this so I can read it. So older adults are at highest risk of getting very sick from COVID-19. More than 81% of COVID-19 deaths occur in people over 65. Well, that's those two lovely people right there. And I've got a lot to live for. I got a lot more living to go. And these were stats from the CDC. I put the hyperlink down there if you want to look up more. But the number of deaths among people our age, 65 and older, is 97 times higher than the number of deaths among people ages 18 to 29. I can tell you, I got another one of these girls on the way. I'm going to have 4 granddaughters. I'm not ready to go. I'm ready to be still be a cool grandma. Okay. So that was kind of startling, statistic for me. And there we go. And this is a picture of many of my friends and family that are in my inner circle. And if they get severe illness from COVID, they're more likely to be hospitalized, need intensive care, require a ventilator to help them breathe, and they're more susceptible to dying. And, I can tell you, some of these people have, there's my daughter-in-law, she's pregnant. I have friends who have substance abuse issues, have struggle with alcoholism. I have friends that's the best breast cancer survivor. I have nephews who have congenital heart defects and learning disabilities. And one of my husband's best friends just diagnosed with pancreatic cancer. There I am with my dear Aunt Sue. Maybe many of you maybe heard talk about her. She's a post-polio patient. She's 87 now. I just visited with her, and she lives in assisted living, and she's got a lot of lung damage from polio. She's very vulnerable. I have, relatives that have obesity and in remission from lymphoma. I have relatives and friends here with mental illness, eating disorders, and inflammatory bowel disease. So this is my inner circle. And if you think about who's in your inner circle, I bet there are a lot of people you want to protect too. And we want to, and I want you to protect these as MAs, get them treated right away, learn about that. So another little busy slide here, and I moved y'all down to the bottom, the page. Outpatient treatment and hospitalization. This is about outpatient treatment. That's our niche. But treatment in the hospital, just brief on that, is to slow the virus down using antiviral meds, to reduce an overactive immune response. You've heard of that cytokine storm. That will require, hospitalization, and treat, severe complications. And putting people on blood thinners to prevent blood clots, to the vessels, kidneys, the brain, the heart. I mean, it can really damage. And I'll focus a little bit, go over here to treatment outside the hospital. Again, we want to treat people that are at high risk for the disease progression. And of course, over age 65. So a number of things have been issued by the FDA. And for EUAs, the emergency use authorization, monoclonal antibodies, oral antiviral medications. Since I started making this show, a lot of those monoclonal antibodies are no longer effective against the Omicron variant. And here's a link here that kind of maybe will keep you updated with that. Again, this is a moving target. I had to really redo my slideshow because so much had changed just like from a month ago. So again, I found on the NIH site what's kind of new in guidelines. And they had studied ivermectin. They looked at studies of that. And again, it recommended against that. I mean, these are things you're probably going to run up against. And I can understand that. I can understand being sick with COVID and wanting anything and everything. Why not try that on me? Let's just see if it helps. And then there was a monoclonal antibody, this Evusheld, that's now not susceptible to the new Omicron. And I just put them up there because I needed to learn them. The BA1, BA1.1.1, the subvariants of the Omicron. And just thought it didn't hurt to look at those and see that. I hear so many numbers on the news, it just all kind of runs together. So I wanted to get familiar with the names of the latest ones. And the EUA, you hear that a lot, emergency use authorization. That's from the FDA to help strengthen the public health protections. It not only includes infectious disease threats, but chemical, biological, radiological, nuclear threats, and the use of medical countermeasures. This slide was going to be the bulk of my show. It's from the NIH. And I found this at the beginning of the year, pulled it out here, and I was looking for another one. But the monoclonal antibodies, this table is excellent. And so I looked for a newer one, but I couldn't find one online. But these are no longer recommended or even authorized for use, these monoclonal antibodies with mild to moderate COVID. The oral antivirals are, we can talk about them. Convalescent plasma, okay. No. So this is an outpatient treatment. Oh, time for a drink. It's kind of fascinating stuff. It isn't new. It's been used and studied historically in many instances. It was used in the past to fight polio, hepatitis, flu, and many other viruses. It's plasma that's collected from people who have recovered from the disease. In this case, we're really looking for COVID, patients who have had COVID. And it's assumed that their blood will have antibodies for that disease, because those antibodies help that person fight off the initial infection. The thought is that these antibodies present in plasma of people previously infected and recover will help treat patients who are maybe not able to fight the infection themselves. Maybe they're, suppressed immune system, or maybe they're taking immunosuppressant drugs. So it will do that. It's important to know that convalescent plasma is not a vaccine. It's it results kind of in it's a passive transfer of antibodies. It's kind of how like I can't think of the respiratory RSV in children, that it's not the vaccine for that is just transferring antibodies that have been made in other people to that's primarily used in premature infants to help keep them out of the hospital in the winter months, November through maybe through March. But anyway, a vaccine will stimulate a person's immune system to create the antibody for themselves. But the convalescent plasma antibodies are just passive transfers of antibodies to your patient. And they have one specifically called COVID convalescent plasma, and it's CCP. And so I've been kind of using the word antibody. It brings to mind the monoclonal antibodies, which have been widely used and proved effective for many people. So my question I asked myself was, how does the convalescent plasma antibodies compare to monoclonal antibodies? And in general, antibodies are proteins that are normally produced during infection. They can be made in the laboratory, and those are known as the monoclonal antibodies. Both plasma and monoclonal antibodies have the same active ingredient. They have antibodies. Therefore, if one works, the other should work. And that's been the experience. And then I just threw in just kind of defining titer. You hear that word titer often with antibodies. Maybe when you recall going on your internships, you had to get titers to pulled to see, blood tests to see if you were immune to chicken pox or measles, that sort of thing. And so it's a word that's used to kind of just tell us the number of antibodies a person may have. So somebody may have a lot of antibodies, so they have a high titer, and someone may have low antibodies, that will be a low titer. Obviously, when professionals are looking for plasma, for people to donate, they look to see if they have, high titer to the antibodies. I don't know if they do it where they're actually drawing the blood or taking the blood, but certainly that's something that can be tested in the lab. So I found out what's new. I went to that good page there, NIH guidelines, what's new. So I found that convalescent plasma is now insufficient. There's as far as they recommend against the use of the COVID convalescent plasma that was collected prior to the emergence of the Omicron variant. And I was looking at when that sort of became epidemic in the United States, and the Omicron variant was found to be the dominant virus in all states, US states and territories in December of 2021. So I really didn't find a lot of information. Are they throwing this stuff out? Are they still using it? But there hasn't been really sufficient evidence that to recommend either for or against the use of a high titer, the CCP, the COVID convalescent plasma that was collected after the emergence of Omicron. So I imagine that the companies that make this, they definitely have dates on it, and they can probably tell, which convalescent plasma would have, collecting the new plaque with the new variants, and could tell that. And so I don't know if this is really a current option. Maybe some of you have had it. Maybe had a neighbor or a friend or a family member that's had it. So it is wonderful that we can now make these monoclonal antibodies in a lab. They're artificially manufactured, and I couldn't find a lot on it, or I would put a slide on it. But my hope is that because they are artificial manufactured, that they'll be able to tweak this to match the current virus, variants that are out, circulating right now. But I couldn't find information on that, or any that I thought was, very, very accurate. It wasn't like from a .com site, and didn't want to do that. But they can make these antibodies, pretty specific to fight the COVID-2 vaccine. But keep in mind, this treatment cannot, and definitely it's not used as a replacement for the coronavirus, the vaccine. And that's the best prevention. So a little bit about monoclonal antibodies. Well, they block the viral attachment to host cells. They have a 70 to 87% reduction of hospitalization deaths. That's phenomenal. They were very active against the Delta variant, but not so much the Omicron variant. They need to be given within 7 to 10 day window of symptoms. They're not given to patients who are hospitalized. They're not given to patients who require oxygenation. You might, run up against some people upset about that. When people need hospitalization or oxygen, generally monoclonal antibodies do not help at that point, and they don't give them. And that few adverse reactions, I'm going to move forward a little bit. again, so people that considered kind of high risk, older than age 65, obese, pregnant, diabetes, immunosuppressant, lung, heart, kidney, chronic disease, sickle cell, neurodevelopmental disease. People who have maybe a trach, gastrostomy, that there's a candidates. So that's a slide I had to sort of cross through right there. That's no longer accurate. So, but these two down here have monoclonal antibodies are still being used. And so I asked the question, why don't they work? Why don't they work as well? And so the Eli Lilly and the Regeneron monoclonal antibodies were directed against the spike protein of the SARS-2. And Omicron has at least 32 mutations and a deletion in the spike protein. And those treatments no longer bind to the virus. So there you have it. Slides in case you want to look up those there. Wanted to define pre-exposure prophylaxis, and that's the use of medication to prevent the spread of disease in people who have not yet been exposed to the disease. And post-exposure prophylaxis is when the medication is taken after the person's been exposed to a person with COVID. This was updated as far as April 29th, 2022, a few weeks ago. There's no product now available for post-exposure prophylaxis. This virus has outsmarted us again. And how does a monoclonal antibody compare to a vaccine? The vaccine offers much better protection, much more lasting better protection. And there's actually a lot more efficacy and safety data on vaccines than they have on monoclonal antibodies. But if a monoclonal antibody is still the best choice for your patient or yourself, remember that time frame. Get on it. Start using it. Remdesivir is now authorized for use in an outpatient setting. It's a broad spectrum antiviral med, and originally it was developed to treat Hep C and Ebola and Marburg virus, but it is effective in COVID too. The oral antivirals, Paxlovid, they halt replication. It has an 88% reduction in hospitalization, has a small, narrow treatment window, 5 days from onset. Again, it won't be given to people that have severe or critical COVID. It's not used in pre-exposure or post-exposure or prevention of COVID, and it's not used longer than 5 days. It's easy to use. It's oral tablets. It's contraindicated in an amazing amount of drugs. Again, it's because of this, what they call a CEU P3A enzyme, liver enzyme. It is phenomenal, the number of common drugs and classifications of drugs that people would take. I do have a link on here for you to go to and look at that. But this is where you would be, a very good drug history is imperative before a patient would start this. And hopefully, there are computer programs that compare, what people are taking, but we want to encourage people to be really honest about it. Even, St. John's wort is on there. It's contraindicated if you take the St. John's wort. Some of the common anticoagulants, a lot of the calcium channel blockers. So the way it works, it's 2 pills, and the nirmatrelvir stops the virus from copying itself, and the ritonavir helps slow down the breakdown of the nirmatrelvir, and kind of botched that up a little bit. So it makes it last longer. So interesting content. The molnupiravir, which is another oral antiviral medication, 30% reduction in hospitalization. Again, that same sort of narrow treatment winter, 5 days of symptoms, not used in people less than 18. Again, not people who are hospitalized, kind of the same thing. It's not recommended in pregnancy, breastfeeding. I kind of want to get on that. This is one of the trade names. I believe this is released in the United States. It stops the virus from copying itself, but it does it in a different way than Paxlovid does. It looks like a genetic building block that the COVID virus needs to use to copy itself. So it inserts itself into the genetic material, then the virus cannot copy itself. Again, a link if you want to get more info about that. And just a nice comparison there. I wanted to bring up some sort of interesting things about the molnupiravir in sexually active individuals. It has been shown in animal studies to have reproductive toxicity, and the EUA states it's not just the female, but also in the male, that men who are sexually active with individuals, women who have childbearing potential, should be counseled to abstain from sex and use reliable method of contraception for at least 3 months during the treatment and at least 3 months afterwards. On their site, it said the medication affects the sperm. They weren't sure exactly how, but it's a little bit of a change. I mean, something very important. I mean, we don't usually think of medications affecting men's reproductive system. And here we know that it causes fetal toxicity. And wait a minute, my time's up. I've got just a few more if you want to hang on. But this would be a very hard ethical decision to make, to put a pregnant woman on this. You know, it might be the drug that best benefits her, but they're recommended use after 10 weeks gestation. And there's a whole lot of stuff about, you know, informing the patient, you know, signing papers, and enrolling them in a sort of pregnancy surveillance program. So it's real clear. And if it's usually contraindicated pregnancy, the same thing with nursing. And it's recommended that lactating women don't use it during while they're using the med and up to 4 days after, and they need to pump to maintain their supply. And so just a little few things about the plague. You know, we came into this very different from past plagues. We were able to rapidly sequence the genome. We could track its spread. We invented and deployed genetic tests that could quickly and accurately diagnose the infection. We tracked people around the globe with their mobile phone data. We have great ICUs, computerized ventilators, new classes of antivirals, a deep understanding of pharmacology and vaccines. And we got the internet, so we can share information instantly. Okay. Generally, we use pharmaceutical interventions to stop a pandemic. There are non-pharmaceutical interventions as well. Individuals, from, you know, hand washing to wearing masks. There's collective actions, usually coordinated by governments, closing borders, shutting schools, banning large gatherings, disinfecting public places. These impose a lot of burdens on people, especially those who remain or appear uninfected. And so, you know, there's a lot of conflict. I mean, the mask became, you know, don't wear a mask, you're for freedom, wear a mask, you know, you're very virtuous. And so it was tempting to call this COVID epidemic the perfect storm. You got a virus that mutated quick, it found the right host of that. They had an encounter with the first human right at the time of the Chinese New Year massive migration. 385 million people moved at that time to leave their homes, to go to their families. I mean, it's kind of equivalent to our Thanksgiving. Our Thanksgiving, 53.4 million people travel at Thanksgiving average. That's 385 million. And then certainly, we're in a time of history when we have international air travel. It implies that this pandemic was a rarity, but it wasn't. And infections and epidemics are much more about the germs that cause them. You get in who gets sick, who gets well, who gets treatment, who gets access to vaccines, who doesn't want vaccines, who wears a mask, who doesn't, who can work from home, who can't. So the roots of ill health really lie in a lot of social circumstances. And plagues, how do they end? Well, from an evolution point of view, pathogens, it's not in their best interest to kill its victims. The SARS-2 will become endemic. I mean, this is predicted. It will regularly circulate among us at some low level. It's connected to herd immunity. We're not sure what that herd immunity, what percent that's kind of going to need to be with this particular pathogen. But herd immunity, prevents the virus from having a lot more difficult time reestablishing itself due to generally a well-vaccinated population. And usually there'll be only occasionally small outbreaks among non-immune people. Respiratory pandemics reoccur. Influenza has been steadily appearing for a long time. We just live with, great public health measures, and bad flu pandemics tend to occur every 50 to 100 years. This won't be our last pandemic. We were caught unprepared emotionally, politically, practically. We didn't have a collective understanding of the threat we were facing. And I thought this was an interesting, I didn't write this, but epidemics are always accompanied by emotional pathogens of fear and denial. We've seen all of it. So a few positive outcomes of COVID, that's COVID-19 pandemic, and not in any order, but just, one of the biggest things was addressing the longstanding problems in our society: economic inequality, racial injustice, healthcare inadequacies. It pushed vaccine innovation, more automation, increased telemedicine, reimagined education. Here we are. It turned cafes into takeaways and gin distillers into making hand sanitizers, a new sense of appreciation and gratitude. I don't think, many of us had questioned how life as we knew it could be taken away from us so fast. It, awakened us to the importance of public health. We're addressing climate change. CO2 emissions went down that year we were on lockdown, It shifted a focus on access to mental health. And it's rejuvenated a sense of community because of self-isolation. I mean, we're social animals. So I want to recognize we just passed this milestone this week, and 1 million Americans had died with COVID-19 this week. And so I was wondering, why the flags were flown at half-mast, and that's why. So keep up. Well, ta-da! I'm about finished. Keep up with what's new. There's a tsunami there of information coming at you. And then my biggest thing that a challenge is how we communicated since March. In one word, Zoom. How many times have you been told you're on mute? Thank you.
Thank you so much, Carol. That was amazing. I don't know how you pared that down because last night when we met, it was 89 slides. So
No, it's-
good job.
And I talk pretty fast for a senator.
That was such great information.
Yeah, they both were.
That's perfect.
So,
Yeah,
so,
both
Great.
amazing.
yeah. Well, thank y'all for attending.
Thank you.
So good to
Thank
see you.
you.
Stay well.
I do have a little announcement to make. I'm just going to share my screen. Can you all see the slide on mental health first aid?
No.
Do I need to do something with mine here, Catherine?
I don't know.
We
Which
still
is
see
nice.
the slide from, yeah, Carol.
That says Zoom.
Okay, let me see what I can do. I'm back in the controls.
Thank y'all for staying.
I don't see anywhere for me to click this off, Carrie. Wait a minute, where do you have your, there you go.
Up
Stop
the
share.
top, there it is.
I got it.
Great. Okay, so just a real quick announcement. So I sent out an email. So now can you see mental health first aid?
It says started. Oh, there it is.
There it is.
Okay, so I sent out an email just kind of getting a estimate of when people could take this seminar because we had 3 options and it has been selected. This was one choice. So this is going to be sponsored by Mental Health Partners. It is a 1-day, 8 hours. You get 8 hours of credit. Now, normally the cost is $35 charged by Mental Health Partners. But they're waiving the fee for the event. However, because we have to do it on campus, there's some minimal fees that are going to be involved. So you'll only be charged $15 for an 8-hour session, and you'll get the certification in mental health first aid. So you'll get a certification. So the date, yeah, it's amazing. So you'll get all of your materials, your book, and the speaker will be paid another way by Mental Health Partners. It's Saturday, September 24th. We thought if we went to the end of our selection for dates that everybody would have time to rearrange schedules and put this on their calendar if you want to attend. It is restricted to 30 participants. So that's it. Once we reach 30, we have to close registration. It is on site. We have to be on camera. You have to be in person. There's no Zoom for this one. You have to be on site. So if you are interested, you just shoot me an email and I'll put you on the list of participants. Okay, and I am going to